Good evening, everyone. Welcome to the first webinar on behalf of the Bladder Cancer Seek Group in the EAUN. We are very happy to be able to provide you with a nice, at least we think, session tonight, getting it right first time. We have an excellent faculty tonight who will introduce you to different approaches how to get it right the first time. I also like to thank you, the European School of Urology, to provide technical support to make this webinar happening, and also a warm thank you to McGrath, who kindly support us with this session tonight. And before we really get going, I also have some housekeeping rules. We have, by the end of the session, the whole session, you will have the opportunity to ask questions to the panel, and you will also have to fill out a questionnaire which will be provided to you after the webinar. And in order to get your credit for participating tonight, you will get a link where you can acquire your credits, and it may not be tomorrow you will get this link, but up to 1 week, and you will be able to apply for your credits. First of all, I also like to thank Chatterton, who is my co-chair on the Bladder Cancer Seek Group, who kindly supported me with recommended the excellent speakers from the UK, and I'm also proud that we could present Bjerggaard Jensen, who is a professor from Denmark, to give his alternative perspective on getting it right the first time. So the floor is yours, Catherine.
Thank you, Bente. My name is Catherine Chatterton. I'm a bladder cancer clinical nurse specialist working at Guy's Hospital in London. And I'm also, as Bente said, on the EAUN Special Interest Group. But without further ado, we've got a fantastic lineup. First of all, I'd like to introduce John McGrath. He is a consultant urologist at the Royal Devon and Exeter Hospital with a wealth of experience, and he specialises in the treatment of bladder and prostate cancer and is the national clinical lead for England for GIRFT programme. So whom better to give us an introduction to getting it right first time. Over to you, John.
Thank you, Catherine, and Bente, and to the EAUN. It's a pleasure to be here and a topic that is very close to my heart and something I feel passionate about. I'm going to talk about the Getting It Right First Time programme, which Kat herself has supported us with, and I'll reference some of the work that we've done. So hopefully you can see my slides okay. I'm a consultant urologist by background but along with Kieran O'Flynn, lead the Getting It Right First Time programme in urology for England. And as I'll explain, we're extending beyond England. Disclosures for this meeting. And what I wanted to cover was a background to GIRFT, what is Getting It Right First Time, how do we do it, the methodology, where are we up to, tried to pull out some key observations in nursing. We want to go beyond guidelines and have pathways and best practice and think about how we make that happen. And by doing so, I'll be covering the GIRFT Academy, which is we've used, and a little insight into what's coming from the GIRFT programme. It's not often that urology is linked to orthopedics, but GIRFT was started by Professor Tim Briggs, Professor of Orthopaedics at Stanmore, the Royal National Orthopaedic Hospital, because he could see there was massive variation in clinical care, which meant massive variation in what patients experience by postcode, depending on local hospitals. There was variation in day case rates, length of stay, readmission rates, infection rates, the cost of implants, the cost of care, litigation. Everywhere you looked, there was variation in the role of nursing and other professionals within surgical services. And so that orthopedic programme rolled out into all surgical specialties, including urology. No, not all variation is bad. Variation in care, of course, is associated with innovation, is trying new things, is trying to bespoke what we do, but it's the uncontrolled variation that doesn't need to be there, that really puts patients at risk of having care that differs depending on where they live, the hospital they attend, and the team that looks after them. We use a clinician-facing portal for data called Model Health. And this is an extract of a graft. We've got 126 urology units in England, and each of these bars is one of those 126 units. And I've just chosen a couple of metrics that we look at to see what the variation is in pathways. We believe the day case pathway is the best pathway for suitable patients. Patients have been interviewed and would agree that they would rather not stay in hospital for care unless necessary. What you'll see in England is it varies between 0% of patients, so no one getting a day case pathway, through to 80 and 85%. There must be unexplained variation in that degree of spread. This is a scatter plot. Each unit's now a red dot, and the red dots represent 126 units. What you can see is that the day case rate has no association with readmission. So the highest day case rate in England, which currently is in Portsmouth, has got one of the lowest readmission rates. So the way that it's not safe doesn't hold up. So again, variation that is a real scattergram. There's no pattern to this at all. And then if we look at centralization of major surgery, so bladder removal, cystectomy, again, we're reasonably centralized in the UK, but even with that, each bar, there's about 50 hospitals that provide cystectomy. And you can see that we've got those doing nearly 200 cases. Small tail down here of centres which actually, since this graph, most of those have stopped, but still variation in care. And we know that volume affects outcomes for patients. But what about other aspects and what's pertinent to tonight? Well, from a specialist nursing point of view, staffing levels are variable. The role that specialist nurses have varies unit to unit. Some are inappropriately paid and inappropriately banded in terms of their seniority. They may be taking on roles in one trust that's seen at a lower band than counterparts in another hospital. The facilities that are available differ, the costs, the ability to innovate, and of course, what distinguishes the best practice pathways from those that aren't performing well is often leadership, clinical leadership, that's nursing leadership, medical leadership, and good management in terms of making things happen. In terms of the GIRFT approach, what do we do? What's happening under the bonnet? Well, it's a national quality improvement programme. So in England, we obviously are working within a public health system, funded publicly, and we work across the whole of the UK. I've mentioned already that's about 126 units, and those are actually organised into networks, 48 networks, which is where the more complex surgery happens across 3 or 4 hospitals. The aim is to improve care. We're not regulators, we're not inspectors. We're after reducing variation, led by clinicians, so people who walk the walk day to day, and hence with the academy that I'll come to in a moment is why Catherine and colleagues have been involved in those groups. We work with clinicians who deliver this care, and we look at what best practices and how that might be rolled out nationally. We use data to drive that. If you show clinical teams data, they tend to change if the data doesn't look favourable, and we allow through the model health system the ability to benchmark against peers. We do deep dives, which I'll cover just in the next slide, and then we'll also talk a little bit, just for a minute or two, about implementation. I'm actually dialing in from Northern Ireland, and although Northern Ireland was not within this programme, we've now been commissioned to review. We're going across all hospitals over the next 4 days in Northern Ireland to look at getting it right first time. We started reviews in Wales, and we'll be attending, though not reviewing at present, attending some of the meetings in Scotland with the view to whether the methodology can extend beyond England and into the other devolved nations within the United Kingdom. The data that we use is hospital episode statistics. That records what's been done by whom, and then I come more process measures such as length of stay, readmissions, the number of procedures a unit is doing, the trends, our day case rates improving, our numbers dropping, etc. And then it's presented back to the clinical teams through a more user-friendly portal, the model health system. So now any member of the clinical team in England at present can log in and they can see in real time almost. It's updated every quarter, so we're only ever 2 to 3 months out of date. They can see the day case rates for not just bladder cancer metrics, bladder outflow surgery, TURBT, emergency stone surgery, all sorts of things that can act as a barometer for the unit. This is what actually happens. Starting on the bottom left, we construct the data, we send the data to the hospitals in a data pack. We issue a letter, a summary of the findings. We come into the unit for a couple of hours and we go through the data and the letters, and we make local and regional recommendations. On the basis, we've just been back around all of the units over the last 2 years. We will write a national report shortly where we'll highlight areas of variation. One of those will be bladder cancer care and bladder cancer pathways. And then we try and deliver academy guides, which is how do we change some of the areas where there is unwarranted or large variation, and try and complete this continuous improvement cycle. We have a research fellow who's evaluating the program, which shows that the program is effective. So just briefly then, how do we change the old way to the new way? With these guides, there is one on bladder cancer. Another key areas within urology. They're designed for managers, operational teams and clinicians. So they're not just a guideline based on the evidence, but how do you implement it? How do you make sure that patients get the same offer, the same treatment every time, and that there is consistency and there is high quality, and how do you measure it? And the model health system is really how we measure it nationally, and how teams can look at that locally. The bladder cancer one you can download from the urology section of the GIRFT website. It emphasizes prompt treatment for high-risk disease, specialist nurse support, shared decision-making, day case pathways, etc. And we're really working hard on a single post-operative installation of mitomycin C in theatre or recovery as a day case route. We're offering additional guidance through the evidence-based intervention program, which will come out to support this. What about the role of specialist nursing? It is highly variable. It is an area of variation. Although nearly all units have a cancer nurse specialist, their workload is highly variable in terms of what they're asked to do. There seems to be a lot of reviewing the workforce, and that's unsettling and can distract from the day job. Units have no involvement of specialist nursing through to those that are almost solely delivered specialist nursing, nurse practitioner type models of care. This is also, if you go to our website, you'll see that we place a lot of emphasis on urology investigation units, which is where we try and co-locate the diagnostics, specialist nursing teams, the biopsies, transurethral laser ablation. You're going to hear about some of this tonight. Post-operative mitomycin or courses of mitomycin, etc., a beating heart of urology to make sure that we've got consistency. And those guides, again, are written in collaboration. This is Claire Waymont, Sarah Hillary as past president and current president of BON, and with BOS as well, to ensure the profession has buy-in. So closing then, what are the next steps for GIRFT? We are doing a national report to be out later this year. We are going to highlight the need to focus on bladder cancer. We're working on the green NHS and the impact that transurethral laser ablation and day case has in offsetting carbon impact. And we're also going to focus on the workforce as well to make sure that it includes that extended members of the workforce. So in conclusion, there is still wide variation. We think standardization, quality improvement is key. Specialist nursing, urological nursing is at the heart of this, but there is variation in its provision and the roles, and we want to try and endorse how the training, the extension of roles is important. It improves patient care, and I think we can go further with that. To do that, we need to measure, we need to have data, we need to show that care is improving. And without implementation, without the academy style model, the process is set to fail. So we really need to go beyond written documents and get it off the page and get patient care in line. So Catherine, I'll hand back to you. Thank you very much.
Thank you, John. Great insight there into GIRFT, a whistle-stop tour, and certainly, feel the passion that we're all trying to sing from the same hymn sheet on that inconsistency there. As I mentioned, we'll leave questions to the end, so please enter them in your Q&A section in the bottom of your Zoom. Now I'm going to introduce Mr. Malde. He's a consultant urologist working at Guy's and St Thomas's Hospital in London, and he specialises in non-muscle invasive bladder cancer and functional urology, and is an associate member of the EAU guidelines panel. Sachin's going to take a closer look at learning experiences and future ongoing management in bladder cancer care for patients with GIRFT in practice, specifically optimising outpatient blue light laser ablation. Thank you, Sachin.
Thank you very much, Catherine, and thanks for the invitation to do this talk. It's a pleasure to talk to you today about outpatient blue light cystoscopy and laser ablation. So hopefully you can see my slides now. So we just heard a lot about GIRFT, and two of the key factors or important points from there were about outpatient services and day surgery, and trying to move some work into the ambulatory setting, as well as extending the role of specialist nurses. And I think that this topic of outpatient flexible cystoscopy, blue light cystoscopy, laser ablation of bladder tumors is an ideal area that covers these areas of GIRFT. So what are we talking about with outpatient tumor ablation? Well, this is essentially for patients who have recurrent bladder tumors, and they're ablated either with diathermy or laser in the outpatient setting. And it's already widely done. It's been done for years, and it's in the EAU guidelines for very select groups of patients, where you can consider, based on the tumor factors and the patient factors, outpatient based fulguration. And we reviewed a lot of the cohort series that were out there on outpatient bladder tumor ablation. And overall, the data would suggest that if you select patients well, it can be a safe and effective and cost-effective option for a lot of patients. So just by way of a quick review, what are we talking about when we're talking about blue light cystoscopy? And I'm sure you will know this, but essentially it relies on this pathway, which is the heme biosynthesis pathway, which happens in all our bodies to produce heme, which is an essential component of hemoglobin. But in cancerous cells or precancerous cells that are more rapidly dividing, they have a greater capacity and need to convert more of the precursor chemicals into heme. And so we can use this to our advantage by instilling into the patient's bladder an hour or so prior to the procedure this chemical hexaminolevulinate, which is then taken up preferentially by cancerous cells. It goes through this pathway, and one of the chemicals produced is a fluorescent chemical, protoporphyrin. So when you shine blue light onto these areas in the bladder, wherever this chemical has been taken up most, it typically shines bright pink. And essentially, it allows us to identify areas in the bladder that we may have missed on standard white light cystoscopy. So it's an optical enhancement technique. So why do it? Well, as you can see in some patients from that picture, you can kind of see it's much easier to visually identify abnormal areas you may miss. And again, there's a strong rating in the EAU guidelines that if equipment is available, you should perform fluorescence guided or PDD photodynamic biopsies. And there is evidence that it can improve detection of tumors, that it can reduce recurrence rates. The evidence for reducing progression is weak, but it's likely to be cost effective, especially if you can move a lot of this into the outpatient setting. So is it feasible? Well, this is old data. This is over 10 years ago now. This group published their experience with outpatient blue light cystoscopy and biopsies, and found that actually there is a significant improvement in terms of your ability to detect tumors. So 30% plus of extra tumors were found on blue light that were missed on white light cystoscopy. And then the US group, is from the kind of US blue light users group, again took this further on, looking at the effectiveness of blue light cystoscopy in the surveillance of bladder cancer. And again, very similar findings, 30–40-ish% range plus of new tumors being picked up that were only seen on blue light cystoscopy. And so clearly it does have a role in improving detection of bladder tumors that you may miss on white light cystoscopy. One of the downsides was that there is a 9% false positive rate. So in other words, in 9% of patients, you would do a blue light cystoscopy, find an area which you think may be abnormal, but then on subsequent biopsy was found to be benign. And so one of the criticisms was that actually 9–10% of patients are undergoing an unnecessary procedure under anesthetic. But if you combine blue light cystoscopy in the outpatient setting with biopsy or fulguration, then that bypasses that kind of disadvantage. So how about outpatient blue light cystoscopy and fulguration? And what is the evidence like for that? And again, there is data out there and good data in cohort series, which again show similarly that you pick up more tumors with blue light. And actually the majority of patients, you see across these series, the majority of patients can be managed with fulguration in the outpatient setting, with only a small number needing TURBTs in theatre for various reasons. So who would be suitable if we think it's a feasible option and it detects more tumors and you can manage some patients in the outpatient setting? Who's suitable for this pathway of management? And again, this is from the US blue light users group in a consensus statement with various factors looking at likelihood of recurrence, high grade versus low grade disease, whether you have positive cytology but you can't see anything on the standard white light cystoscopy, and in terms of the types of tumors, whether they're small and low grade. And overall, it seems to be generally recommended that for intermediate and high risk disease, it should only really be done in those where it's going to lead to a change in their management. We use it in the setting of post-BCG biopsies. If patients have abnormal areas, red areas that need biopsy, we move that into the outpatient setting. Similarly, patients with positive cytology but negative white light cystoscopy. But it's also very useful for low-risk disease, low-risk patients who have frequent recurrences, to try to identify all areas of tumor recurrence, to fulgurate, and hopefully increase the time interval between surveillance cystoscopies, which is one of the biggest burdens of low-risk bladder cancer management. And so what about the timing? When should it be done? This is a very good study, randomized white light versus blue light, looking at doing a blue light cystoscopy at the first check cystoscopy following TURBT, so done at 4 months. Actually, it's a very interesting findings with a relative reduction of 33% at 1 year. Very similar to the relative risk reductions we see with giving mitomycin, for example. And so there's a possible role for using this as routine in the first surveillance cystoscopy after a TURBT. And again, confirmed in the real life setting, prospective evaluations of large numbers of patients. And again, most patients, you pick up extra lesions on blue light. Most can be managed with office outpatient biopsies, and a few need to be then sent for TURBT. And patients tolerate it well. Pain scores were low. Patients would have it again. Anxiety is lower. So it's a very good option for elderly or comorbid patients who wish to avoid a general anesthetic. And I'll just show you one very quick video just to highlight this. This is actually Catherine in the outpatient clinic doing a blue light cystoscopy followed by tumor ablation. And with all of these procedures, we start with a very good white light cystoscopy, mapping of any areas that look abnormal. Then we switch to the blue light to see if we've missed any lesions. There are any extra lesions that we can pick up. And you can see here that there are some areas that we may have missed on standard white light. Obviously, the obvious tumors we will still find. Some of the flat areas we will still find, but there are some areas like this which may be very early papillary tumor that we may have missed. We may not have laser ablated if we were just focusing on this one papillary tumor. And so blue light can be helpful in that scenario to help detection. And of course, then the important thing is to try to be able to do something about it there and then, rather than having to bring the patient back to the theatre. And with laser, which is very well tolerated, you can then use blue light to try to guide your fulguration of these areas, and hopefully that will translate then into lower recurrence rates and greater potential intervals between surveillance cystoscopies. So the key take-home messages, I think, are that we know from the data that's out there, it's been done for a long time, that outpatient blue light cystoscopy and fulguration and biopsy is feasible. It can, for high-risk comorbid patients, avoid the general anesthetic. It can move a lot of work into the outpatient setting, reducing the burden of the disease for a lot of patients. But of course, we do still need some prospective analyses to assess cost effectiveness and improvements in recurrence rates over the long term. So many thanks.
Thank you, Sachin. I think alongside GIRFT and COVID, we're learning more about how to adapt and manage outpatients in the outpatient setting for sure. And I'm sure you agree, Sachin has certainly demonstrated how well we're learning to deliver the operating theatre to outpatients for a one-stop shop. And now up, I'd like to introduce Rebecca. She's been working as an advanced nurse practitioner in uro-oncology at the Royal Marsden for over 10 years, and she's a qualitative researcher with a particular interest in looking at sexual consequences of bladder cancer in female patients. She's also an active member of the EAUN and BOWN, and she's going to take us through her experiences and expertise of the nurse in the bladder cancer pathway. So over to you, Rebecca.
All right, so I'm Rebecca, AMP by training, but I also lead a team of CNSs, AMPs, SCPs, and support workers across the uro-oncology pathways. So I'd like to talk to you today about the role of the specialist nurse in the bladder cancer pathway. I've no conflicts to declare. These are the key features of my presentation, mostly sort of based on our experience of working within a bladder cancer MDT in a specialist cancer hospital. So I'd like to start by asking you a question. And I don't think there's any voting option on this webinar, so just points for consideration. So what do you consider to be the main purpose of a cancer multidisciplinary team? So is it, case review? Is it to aid treatment decision making? Is it about interdisciplinary collaboration, shared learning, safety net for decision making, perhaps? Or is it about identifying patients for potential trials? So I guess arguably it's all of the above. So what is an MDT? So Macmillan would tell us that an MDT is a team of professionals working together to plan the best treatments for the patient. They describe that these are the core professionals who are members of that MDT, and here they describe the specialist nurse. They've sort of pulled out the CNS as the key member of that MDT. So we'll talk a little more about perhaps diversification of specialist nursing roles, not so solely focused on the CNS. And it was John McGrath himself who told us that specialist nurses are right at the centre of high quality urological care. So how can we optimise that in practice? So I think, as I've sort of alluded to in my previous slide, a comprehensive specialist nursing team is perhaps what sort of more reflects our experience in sort of the current day workforce. And, why is that important? So here we have the sort of Macmillan described, key CNS-led activity. the key features of which sort of focusing on improving quality of care and patient experience, patient safety, productivity and leadership being the sort of core elements. And then we bring in, the 4 pillars of advanced clinical practice. These are described as quality of care, leadership, developing practice, and, developing self and others. So there's lots of similarity and overlap between the 2 core nursing roles. And, the key features are that, both roles are patient facing and they're focused on, care delivery, quality, safety, and leadership. So let's focus a little bit about the primary functions of a CNS and why they're key within the bladder cancer pathway. So Macmillan and others would describe, the CNS as using knowledge and understanding of a cancer pathway to personalize the pathway for a patient. The CNS acts as the key worker, and GIRFT recommends the early introduction of the CNS to help the patient navigate the pathway and coordinate their care. The CNS uses their knowledge and skills to alleviate psychological suffering and their clinical acumen to reduce risk. Bladder cancer patients are known to have poor satisfaction with care, so then CNS can make a key impact here. And then access to a specialist nurse is associated with improved patient experience and improved patient metrics such as readmission rates and length of stay. Again, the CNS playing a core role within that part of the pathway. And then the CNS uses their technical knowledge and insights from practice to redesign services, based on various metrics that they will be monitoring. So is there room for diversification of specialist nursing roles? So an AMP or an ACP model reflects the medical model, and it's largely sort of focused on, clinical aspects of care. The AMP in most cases would focus on perhaps one particular part of the pathway and care delivery at that time point, whereas the CNS is the continuity throughout the pathway. I think Macmillan would describe that advanced level care isn't essential for the role of a CNS. I think there's lots of scope for debate on that, and my assessment is that there's room and certainly need in the pathway for everyone. A contemporary MDT might look something like this. This is a slightly old photo of our MDT, but here you've got sort of 5 key members of the MDT. You've got your oncologist, your surgeon, your trainee, and then both the CNS and an AMP, all in the bladder cancer clinic.
My name is Katie.
Oh, sorry, here we'll hear from our CNS, and one of our CNSs, we have 1 AMP, 2 CNSs and a support worker. We also have a surgical care practitioner in the urological theatres, working across the oncological and surgical pathways.
My name is Katie, and I'm a uro-oncology clinical nurse specialist focusing on bladder and renal cancers at the Royal Marsden. As a CNS at a comprehensive cancer centre, I see patients from medical oncology, clinical oncology and surgical pathways, and act as key worker throughout their patient journey. This allows for consistency and a clear point of contact. MDT collaboration is ongoing throughout the patient journey and is essential in providing patient-centred care. Throughout participation in the MDT, I can act as a conduit, feeding information from other practitioners to our patients in a concise, personalised manner. Overall, I view the role of MDT and my participation within MDT to facilitate considered and coordinated expert support.
So next, I'd like to focus on whether or not you think a bladder cancer MDT is important for all patients. This is a nationwide Dutch study examining a database of over 2,000 patients with muscle invasive disease. And they found that being discussed at a comprehensive MDT meeting was associated with offering treatment with curative intent and also being offered broader treatment options. And certainly an aim of GIRFT is to promote multi-professional joint clinics to promote the right treatment for the right patient. So next we're going to hear from one of our oncologists who gives an example of how this might work in practice.
My name's Dr. Shaista Hafiz, and I'm a clinical oncologist at the Royal Marsden, treating urological cancers with special interest in bladder cancer. I'm part of the specialist MDT delivering this care, and for me, one of the most important aspects of why the bladder MDT is important comes down to recognizing that bladder cancer patients have a huge unmet need. They have massive delays in diagnosis, delays to accessing appropriate treatment, and poor access to trials. So I would hope that the MDT functions to enable and empower clinicians, both the doctor and the nurse, to make more informed patient-centered decisions regarding bladder cancer care, improving equality of access to all available treatment options, and ultimately improve cancer outcomes and patient experience. What makes our bladder MDT successful and why our bladder MDT meetings are important for patients is that there is a mutual respect between all the different healthcare professionals and specialities. One way we leverage the MDT meeting forum to our patients' advantage, particularly in terms of minimizing delays in bladder cancer in the diagnostic and the treatment pathway, is accepting patients directly from the MDT meeting. So there's not a delay with referrals from the local diagnostic center. And this really has been enabled by working closely with our bladder cancer nurses in the local center. So whatever model is being used, whether it's a joint clinic with a surgeon and an oncologist or separate clinic, working with the bladder nurse to physically coordinate the MDT approach to care helps patient manage complex information in a stepwise, less overwhelming fashion. And there have been times when we've had to run this service without a bladder cancer nurse, so I know definitely the value they bring. And we see that from our own patients' mouths, whether it's in our own institutional surveys or from the National Cancer Patient Experience Survey. The view of patients who do have a bladder nurse compared to those who don't are very different in terms of what information they get, what they remember, whether they get information on financial support or the appropriate emotional support. So if we wish to improve our bladder patient pathway and their experience, involvement of the bladder nurse is a critical part of holistic care.
Thank you. So next I'm going to present a patient scenario for consideration about how you might approach this patient who comes into your practice. So a 45-year-old female, married, she has 2 young children. She presented with T1 transitional cell carcinoma with CIS, BCG refractory disease. She was unkeen on cystectomy. Sort of retaining sexual function was really important for her. She was well read, and she came to our centre for a second opinion. So how did we approach her case? So she was discussed at our multi-professional MDT meeting for consideration of uterine sparing surgery. She had the opportunity to meet with our oncologists to discuss potential bladder sparing options and potential trials that she may be eligible for. She went away, considered her options, and settled upon surgery. So she had a careful pre-operative workup focusing on her sexual function concerns. You know, the AMP and CNS were important in her surgical preparation. She wanted to discuss reconstruction options. Unfortunately, she wasn't suitable for a neobladder, so she settled upon a abdominally catheterizable pouch. And so she had the opportunity to review our cystectomy preparatory films, and also our CNS put her in touch with a previous patient for sort of peer support. And in those cases, we try and match people based on particular characteristics, such as what type of diversion they're considering, but also personal characteristics about, stage of life and activities of living and things like that, that might mean that they can fully understand consequences of the pathway. So she, as I said, she ended up having an anterior exenteration because she wasn't suitable for uterine sparing surgery and a mitral off and off. And she's having ongoing follow-up. She's sort of 3-4 years down the line, cancer-free, and having, she's got good functional outcomes. And the majority of her follow-up now falls to the AMP in that clinic. So now we're going to hear from our primary bladder cancer surgeon about how nursing roles have evolved over time.
My name is Pardeep Kumar. I'm a urologist here at the Royal Marsden Hospital, and I've been a consultant here for the last 11 years. Over that time, I've been involved in the diagnosis and management of patients with bladder cancer across the spectrum of disease. I really enjoy working here. Part of that is that we deliver things as an MDT, as a group, who are all sort of pulling in the same direction, trying to achieve the best outcomes, both oncologically and functionally for our patients. And I think nursing over the years has changed. It has developed. I am more reliant now on my team than I ever was previously. And the way that I interact with my team has changed. At the beginning, it was very much a sort of CNS doctor relationship, and it was quite a defined role. Now I find that we move into each other's roles quite easily, counselling patients preoperatively, carrying out endoscopic surveillance for our non-muscle invasive bladder cancer patients, all the way to the other end of the spectrum of caring for patients who are perhaps 5 or 10 years down the line or even longer following reconstruction. We've developed our ward nursing, CNS level and advanced nurse practitioners over that time frame. Where do I see things going? Well, we already have nursing as a larger part of our theatre team. I think that our colleagues whose background is in nursing will continue to evolve their role. They'll become bladder cancer specialists, so they'll understand the whole pathway rather than delivering one aspect. And I think that can only be good for patients because it means consistency over their pathway. So I see the future as exciting. Bladder cancer is exciting in that we have new treatments, we have new efficacious treatments. Looking forward to another 20 years here.
So what is the future of nursing in the bladder cancer MDT? So we've already heard about the importance of advancing skills and that advanced clinical skills are increasingly important to deliver care across the sort of diagnostic and follow-up spectrum in both the outpatient setting and theatre settings, and delivering long-term follow-up for patients with bladder reconstructions or taking responsibility for cystoscopic follow-up. And in the oncological setting, nurse practitioners are increasingly important in reviewing patients and prescribing systemic therapies. However, I'd argue that with evolving and advancing clinical skills, the fundamental skills of the nurse specialist as key worker mustn't be lost. And it's essential that sort of managers and commissioners value this fundamental quality enhancing role and fund sufficiently for all aspects of care to continue. We know that bladder cancer patients experience disparity, access to appropriate treatment, access to trials. There's a paucity of evidence on novel therapies, but also patient experience. So clearly, by virtue of your attendance today, you've got an interest in bladder cancer. But I wonder if in your organisations that you feel you have sufficient bladder cancer specialist nurses or, sufficient bladder cancer specific nursing time. Have you been offered, sufficient specialist training and development to, develop and evolve roles? and supported to access this training. GIRFT state that an empowered nurse increases productivity, retention, safety, and quality of care. So a key priority must be that we develop a specialist bladder cancer workforce, with sufficient time within, job plans to enable the supportive aspects of a specialist nursing role as well for these complex patients. There's also an enormous opportunity for multidisciplinary or even nursing research to investigate areas of unmet need. So I think there's lots of scope for nurse development within bladder cancer. That's the end of my talk. Thank you.
And the next speaker is Professor Bjerggaard Jensen. He's a professor at Aarhus University Hospital in Denmark, and actually one of the leading persons in the European bladder cancer community. Jørgen also on daily basis run a research group in Aarhus, which for the moment I think consists of more than 10 PhD students plus more candidates coming in. So it's quite a big and impressive work you have done here. Jørgen Bjerggaard is also one of the first mover in designing Scandinavian cancer packages, which actually was one of the first approaches, I think, in the world more than a decade ago. And the cancer packages in Scandinavian have the aim to reduce time to treatment for anyone, any patient with bladder cancer, but also assure that the right treatment goes to the right patient, and also, of course, to improve clinical outcome, and which again is another approach to getting it right the first time. So over to you, Jørgen. You can possibly better explain the concept.
Thank you very much, Benda, and thank you for the introduction and the invitation to talk about it here. Yeah, as you said, it was something that was made up by the politicians because they thought that cancer patients in the other Scandinavian countries were doing better than in Denmark. So we had to do something to get it right here. Just see, this is our hospital and my office is located here on the penthouse. You're welcome to visit our site. This is the usual mumbo jumbo of conflict of interest, but very important. As Benda just mentioned, I was deeply involved with the design and implementation of the first clinical cancer pathways in urology in Denmark. It's called cancer packages in Danish, where it's the idea is that if you have a patient coming in with hematuria, you have a package ready for it. So it consists of the first investigation, and if there's a tumor, you'll have an appointment already for the TURBT, and you'll end up with a cystectomy. So every patient should go into that pathway. The problem is, of course, that for every almost 200 hematuria patients, you might have one ending up with a cystectomy. So it's quite difficult to have a system where you have 200 available cystectomy appointments. So of course, it will never happen like that when you have fluctuation of your patients and so on. But we started off in 2008 and were very idealistic about it. We described all the routines in the cancer workup for bladder cancer, and that was basically a very good idea. We took all the guidelines and renewed them, and we looked at every single step of the bladder cancer patient coming in of the door and what would happen until they left this planet after follow-up. The MDT was structured here at the first time, and we were given time to have it, so it was not in our spare time anymore. A very good idealistic time, and we also had to estimate a minimum time between the two time points in this list. It turned out that the minimum time was apparently also the maximum time that we should describe for all steps. If all the resources in the world were available, that was what we were told. If all the resources were available, how fast can you do it? And we described that. Oh yeah, how fast can you do it? And even if the patient was admitted or referred the day before Christmas, well, do not take that into account, because every patient is referred Mondays, and of course you're always open at the hospital. How low can you go in the timing? The idea behind that is like the accelerating truck. If you have a truck at the very top of the hill and it has no brakes, it goes very, very slow in the start, but in the end, it ends up in a catastrophe. And the faster you can put in the brake on this truck without brakes, of course, the better the outcome is. And that's the idea of getting into how fast can we do these things to stop the cancer where it is. Of course, this makes sense in some diseases, whereas in others it doesn't. And when you mix that up for politicians, they'll get confused. So they, at some time, decided that 2 weeks is sufficient time, irrespectively of which cancer you have. So if you have a renal cancer patient where you could either undergo active surveillance for the next year or maybe treat them if they'd like to, you have to treat them within 2 weeks or you will break the law. I guess that makes no clinical sense, but it makes apparently political sense to do it like that. What we also were told in the beginning when we designed these is these are ideal pathways. They should only be used as guidance and not as a marker of what's possible in daily routine. That was very good. It was actually mentioned in the first pathways. Then we shifted to 2009, and that sentence was not in the pathways anymore. And a couple of years later, they decided from the government that we had to monitor how many patients we were doing it sufficiently, given that these maximum times or minimum times were ideal goals. So all of a sudden, we ended up in a catch-22. We had described how fast you could do it in the ideal world. And if we didn't do that for every patient, irrespectively of age and comorbidity and so on, we didn't live up to our own rules, as said. Not the perfect way of doing it, but at least we gained some focus on the cancer area, and we gained some resources, but not sufficient to solve the problem. What we did gain was the focus on the cancer treatment, and we also had it more structured than we had had before that. Most recent development was that a cancer scandal, as it's called, they just sacked half of the hospital management in our university hospital a couple of weeks ago, because some patients waited more than 2 weeks. Yeah. So the positive side, as said, we have focus on cancer patient, we have focus on good MDT, and we have it structured in our daily practice. And we aim at not having more waiting time than acceptable, at least. What has happened then? Well, in the sarcoma group, where it may be very reasonable to have a very short waiting time, they looked at what has happened before and after introducing these cancer pathways. And as you can see here, they were introduced in 2008. If you look here at the green line here, that's delay caused by passive waiting time. That's what you're not allowed to have. It was reduced from 20% of the patients to practically 0. And in the same time that they saw that the size of the sarcoma at the time of surgery went from 7 centimeters to 5 centimeters. Whether there's a causal coherence between that, I do not know, and nobody knows that. Maybe it's also just bigger focus on it, but it could be a hint of it. We looked at it in penile cancers, also what happened after we introduced these cancer pathways in Denmark. And there's a lot of timing and a lot of confusion in this here. But what we could see that how many patients were treated within limits set by these cancer pathways was increasing over the years. So something good happened there. The patient interval, the patient delay, however, was the very longest delay of all, and that was not reduced. And in this period, and that was the downside of it. Looking to bladder cancer, that has also been looked at, and how much shortening the time from your first symptom until cystectomy was after introducing the cancer pathways. It was reduced by 1 month, and that's a long time, you could say. But the 1 month was from 240 days to 200 days. So still a lot of lead time from your hematuria until cystectomy. I think it has been reduced after this was published 12 years ago, but still, I think the focus should be in the future on the patient delay in their home, where we still can do a lot of good things for the patients. So in conclusions, it shortens most of the diagnostic workup significantly, and it increases awareness. And this might influence the oncological outcome positively. Well, in theory, it does. Whether it does that much in practice to reduce from 3 weeks waiting time to 2 weeks, I don't know. But still, instead of waiting 2 months for a cystectomy, I guess you'll have a better outcome if you could do it next week. But it can be a political hot potato. Thank you.
Thank you, Jürgen. Fantastic work demonstrated by the integration of the cancer pathways, reducing the diagnostic delay. I'm mindful of the time, so I'm just going to ask all of the speakers to put their videos on. We've got a couple of questions that we've answered and that have come through. I think we've got one here for you, John, looking at the aim of the GIRFT workforce work plan to recommend standard banding for our enhanced and advanced specialist nursing roles. I guess, you know, they're saying this is key so we can train to retrain across all organisations. Is this something that we're looking at?
Yeah, it is, Catherine. It's been really complex to work out who should set that. Doctors proffering on nurses banding, I think, is not a good idea, which is why we involve Claire Waymont and Sarah Hillary in this. The problem we have is that employers, so hospitals, can still have discrepancies in this. So what we're trying to do is suggest through some of the academy documents what the roles are and what sort of bands are typically associated with that. So the urology investigation unit document, which is now complete and just having final sign off, will come out, and that gives a little bit of a steer towards that. But we're, if I'm honest, Catherine, we're nudging gently on that because we don't, as GIRFT, have any sort of mandatory powers to say this is how it should be. We're just trying to suggest that nurses' roles, responsibilities should be reflected fairly, and there should not be variation across organisations in terms of what people are asked to do and how they are then paid, reflected, and recognised for doing that.
Thank you. Roxana, I'm going to email to answer your question. So if you could just send an email to the AUN, I'll answer that for you. And Sachin, I wonder if I could ask you, just with issues with single post-operative installation of mitomycin, looking at that video that we did in outpatients, do you see a role for outpatient mitomycin alongside laser ablation on top of the blue light too? Because it's quite worrying seeing all those bits flying off.
Yeah, it's a good question, Catherine. You know, obviously we discuss it a lot, and I think so. I think obviously we don't know the data for that, but we know that single post-op mitomycin after TURBT has good data, and I think, as you say, whenever we see those bits flying around, you always worry, is that going to then seed something else? So I think it's definitely something that's that we need to study in terms of how logistically you can do it, cost effectiveness if it reduces recurrences. But I think definitely it's a good thought. I think should be studied.
Yeah. And just one question for you, Rebecca, as well. I guess we're empowering nurses, increasing productivity with retention, you know, safety and quality, which we talked about. But just in a brief synopsis, how do you think, what can we do to help nurses manage stress at the moment, as we know that there's a lot of that about?
Yeah, difficult question. I think, valuing your workforce, particularly in sort of challenging financial circumstances. I think a lot of that sort of value added stuff falls to the organization a lot of the time. But I guess as a manager of people, I think, making sure that job plans reflect actual work, I think, is a really key thing, so that, people aren't, expected to, pull out long days out with their sort of job plans, regularly. Simple things like that can make a difference.
Definitely. No, I agree. I'm really conscious of the time, so we must come to an end now. I'd just like to say a really big thank you to all our speakers this evening, and I'm certainly, feeling empowered, and I'm sure you agree it's been a fantastic session, giving us food for thought to improve our bladder cancer services. And please don't forget to look at the GIRFT website too. Again, I'd also like to thank Medac Pharma and also the EAUN for helping us to organise this. And a reminder also to follow the link at the end of the meeting to complete the post-webinar evaluation. And please do take this opportunity to make comments to feedback on topics that you may be interested in for future bladder cancer webinars. You'll also receive a link next week, as Bente mentioned, to complete the questionnaire to gain the accreditation. And please look out for the recording as well. They'll be available on the EAUN website. I hope you all have a wonderful evening, and thank you very much for joining us, and we hope to see you again at our next webinar. Many thanks.
Thanks.